All right, guys. Once again, welcome. Good morning. We are thrilled to welcome over 200 leaders from the city and county government, healthcare, education, nonprofits, faith partners, grassroots organizations, and residents for the release of the 2025 Bexar County Community Health Needs Assessment. It's a beautiful day. It's a chilly day. Everyone looks beautiful in their fall winter attire. Today is about turning data into action, and we are thrilled that you are part of the conversation this morning. I want to give two quick notes. One is you can view the full report by scanning the QR code that's on your program. We also have a little business cards that we've made for you on your tables, and we have extras if you'd like to take those back to your offices, where you can also download the QR report. And then also our program was intended to begin at 9. It's going to run through 11. We may be a little bit off schedule, but we'll get back on track. I'm going to ask that if you have one of these, if you will please place those on silent or vibrate, because we've got lots of good stuff to show you, and we want to make sure that you guys get all of the attention necessary. We are going to have a Q&A at the end of the session. I know you guys have burning questions, especially as we go through the findings and we listen to our amazing panel that's going to be sharing some amazing work that they are delivering in community. But we ask that you hold your questions until the Q&A session, and we'll have our staff come around with those mics to get you started. So to open our program, please help me welcome Mayor Gina Ortiz-Jones.
Thank you. Well, good morning. Good morning. Okay. With the importance of this report, I'm sure everyone shares my enthusiasm, which is why I just wanted to check that, make sure we were all very excited, because it is quite a momentous event to have such a significant report with this rich data. And now you're right, it does call for the action. Most certainly, though, the courage to actually address some of these things that we all know many of us have been talking about for a very long time, right? So, and I think now, frankly, as we are, when I was reading the aspects of the report, food insecurity impacts health through childhood, from childhood through adulthood, as we are faced with the impending freezing of SNAP benefits. So I can't think of a more timely report as we consider the steps our community has to take, must take, cannot afford to not take, in light of what is happening above us. So I know everybody has the memory, has the report committed to memory. If folks would just point to page 45 on, just kidding. No, but I look forward to reading the report in depth, and certainly working with the rest of the city team to make sure we are focused on implementation. Thank you again to the entire Health Collaborative for hosting us, our hospitals, community partners, and neighbors who made this report possible, and being at the forefront of convening the most essential conversation conversation revolving around the health of our community. The Community Health Needs Assessment is a trusted community resource, and the 2025 report gives us the clearest picture of the health, of the state of health in Bexar County. I want to emphasize the word trusted. Again, when we are thinking about the steps our community must take, I don't know if we have lived in a time where there's been so much misinformation and disinformation around public health. So let me foot stomp the importance of trusted community resource. And again, my thanks. This report isn't just statistics, though, right? These realities shape people's daily lives and confirm what many of us see every day. Our community is resilient, but deep inequities persist across our city. Yesterday, I was in fact actually at YWCA, and that 90, as I'm looking at Dr. Rocha Garcia, 90, right, is always, you cross that and you're like, oh, 20 years is shorter. You go the other direction, up 20 years longer. And I hope everyone really thinks that when they cross that highway, because again, those are choices. Those are choices that our community and our leaders make. And again, that's why this report is so important if we ever want to change that number. And obviously we must. I believe that good decisions are driven by data. That should be no surprise to anybody here if you're reading the San Antonio Express News. I think the three most important questions any leader can ask: why not, and where's the data? Where is the data? So again, thanks to the Health Collaborative, we have an in-depth look at our region's unique health needs and priorities. This report is the product of partnerships and community work to understand patterns in our community's health population so we can improve the health systems of everyone. And I'm so thankful that we have a really diverse set of the health practitioners in our community. Thankful that Dr. Wu is here from Metro Health. I also spoke to one of our leaders from one of the community colleges on the community healthcare professionals that do such important work. As we really, again, if we're going to address this, it's everybody from the healthcare administrator to that healthcare worker in our community. The report highlights 5 urgent priorities we must address: mental and behavioral health, where the demand continues to outpace capacity and access remains uneven. This point in particular hit home for me. Last week, I was at Haven for Hope, an organization that's been in existence for 15 years, has served 55,000 people. And I asked them, tell me the difference between a profile of somebody today versus 5 years ago. And they said, today, somebody is older and they have more mental health challenges, right? So when we think about how this manifests itself, not only in health disparities, but no kidding, public health and public safety challenges that we certainly then are required to resource. So how can we look at these things along the continuum and really ensure we're best serving that individual, but also looking at this from the resources that it takes and where does our dollar go the furthest? And it's always on prevention and addressing it early on. The second of the 5 urgent priorities, maternal and infant health, where we still see preventable disparities. Certainly, again, in our own state, where, and certainly given some of the federal challenges as well, this is one that will only become more of a challenge. I think we recognize the inherent challenges as well when we have state leaders that are not interested in collecting the data. But then what does that mean and what does that require we in fact do at the local level to ensure we have a holistic picture of these and certainly the disparities among socioeconomics, but race and ethnicity. Chronic diseases like diabetes and heart disease, which are tied to nutrition and housing, of course, as well asthma, right? One of the main reasons our kids in this community miss school. Housing instability continues to destabilize families. That's the 4th urgent priority that we must address together. And of course, food insecurity impacts health from childhood through adulthood. So those 5 urgent priorities, again, not unfamiliar to us, right? Which is why we need an unfamiliar level of courage to addressing these issues and investing in them. And certainly I and the rest of my city council are committed to doing so. These issues, as we know, are interconnected, and they remind us that health is about more than medicine. Health is about the environment we live in, the food we eat, the opportunities we have to thrive or do not have to thrive. And I appreciate the report isn't just numbers, right? It's a call to action. By incorporating qualitative data, community surveys, focus groups, and interviews, it provides a robust review of our county's capabilities, driven by lived experiences, frontline insights, and actionable recommendations. So if we zoom out a little bit at the federal landscape, the road ahead will be challenging. I have foot stomped that point, I think very, very clearly. Again, we are seeing the impact of federal cuts to funding for Medicare, Medicaid, CHIP, and SNAP that we know will adversely impact our communities and the trajectory of our communities. I think that's really important for us as leaders. It's not just this moment in time, but now what does that mean to the trajectory of our community? As we also know, the FY26 budget had a bit of a deficit that we were able to close. FY27, though, will be much more challenging, much more challenging. That's a $150 million budget deficit. And while there is a plan to close that, it is not lost on me that the very changes we may need to close that budget deficit will in fact impact the very services of those who would be most reliant on them. Again, when you look at where the cuts are coming, CHIP, Medicaid, Medicare, SNAP. So these are the types of things that are kind of top of mind for me as we head into the next budget session. And of course, I'm not unfamiliar with this group. A recent study has named San Antonio one of the most impoverished cities in the country. Our communities are clearly struggling, but the work that you all do is so integral to our support system and informing our decisions to tackle these challenges with data. That's why I'm really excited about, the months ahead as we look to work with the Community Health Collaborative and our partners to turn these findings into a community health improvement plan. Right, Dr. Wu? Yes. With measurable goals and strategies for meaningful change. This is important as we head into, again, it really is about, show me how you spend your money. I'll show you what you care about. As we head into that next budget session, there's lots of analysis, for example, that will show you how many cops you need. But I want that same level of analysis. Hey, show me how many healthcare workers we need. How many folks do we need in Metro Health? How many public health professionals do we need? That's why I've asked, and we're working on this, at the city, we'll be doing we'd call it a war game at the Pentagon, but we don't want to scare folks. So we're calling it a tabletop. But what it does, it's an intellectual exercise to help you understand, if some of these, for example, Metro Health, 50% of Metro Health's budget comes from federal grants, right? 50%, it's about 45 million, if I understand correctly. So if we see a big chunk of that go away, right, and we then begin to see some of the implementation of the federal cuts that we know are coming, what does that mean for us? What do we respond to? What assumptions are we making in our ability to respond to those, working with our county partners, our community partners? And while we're not going to have all the answers, what we can at least try to do is reduce our uncertainty, and then communicate with the community about changes they may see as a result of the changes in our budget, right? So it's again about meeting the need, but about communicating, managing people's expectations in this area where we know we are quite fragile and for which we know there is great need. So I'm very excited about that exercise that we will do here shortly. So while we work in the short term to address these issues, let's also look ahead. By 2040, just 15 years from now, Bexar County is projected to add over 1.1 million people. So to put that into perspective, we're talking about adding a city larger than Austin. Not as weird. No, I'm just kidding. That was a wake-up joke, right? Larger than Austin to our region in a decade and a half. So this growth isn't a speculation, it's a demographic reality, and it demands that we think differently about how we grow and invest in our city and her people. So understanding the current needs of our population and how we can meet them and grow with them will be vital to our longevity as a thriving city. How do we manage all aspects of our community, private and public, to advance mental health supports, provide safe housing, distribute healthy food, and increase preventive care? So this report, I think, will be a critical tool to helping us do that. It's about resilience, equity, opportunity. I believe that together we can ensure that every person in every zip code has the chance to live a healthy and dignified life. When I assigned my colleagues to their council committees, I said everybody's job, regardless of what your actual job is, everyone's job is to do two things. We have to reduce poverty in our community. Think about your work in that way. And we have to ensure that we are making ourselves as economically competitive as possible, right? Reduce poverty, make ourselves as economically competitive as possible. Certainly the findings and the information in this community health needs assessment will ensure we can do just that. Not data-driven, data-informed, right? Data-informed. So thank you again to those that contributed to the report. More importantly, those that are now going to develop their own plans based on the very rich findings in this report. So thank you. Have a great day.
Thank you, Mayor. We appreciate you being here, taking the time to give us your thoughtful comments and really open, right, the conversation that we're going to have today. We appreciate you and, of course, your leadership and your partnership as we move forward. As the Health Collaborative, we're answering the call. We're standing shoulder to shoulder with providers, resource partners to stabilize families facing cuts or interruptions to lifeline services like food, healthcare, housing, education, workforce. Today, again, is a step in coordinating those support efforts together. I'm going to take a personal point of privilege here. I saw Eric Cooper coming in the door a minute ago. Eric, could you please stand? And I call out Eric because he is he's an amazing leader. And every time we have a needs assessment, this is the first person that we go to because we know that the work that they're doing is impactful, but it is so needed. And in a critical time like now, it's even more important for us to really bridge together to expand services and expand access and support our partners at the food bank. So whatever we can do, whatever inventories we have, whatever extra resources we have, make a connection with Eric and his team. They have a big lift ahead of themselves. We've got lots of families that are going to be looking for those resources. And while we as partners, we have a limited amount in our shelves, we need to make sure that their shelves never go empty. So thank you, Eric, for the wonderful work you do. All right. Well, it is my honor to introduce our board chair, Ms. Palmira Arellano. She's the Vice President for Division of Community Engagement at Methodist Healthcare System. She's a founding board member of the Health Collaborative and is a founding partner of this work. With that, Ms. Arellano, I'll call you up.
I'll say my own good morning to you all. Thank you for the introduction. And I'll say it's so, it just makes my heart happy to see so many people here. I think at last count, we have almost 200 people here. All of you all are superstars. And I hope you understand that you have such impact in community. And that's why it was so hard to get y'all seated to start this program because of your passion. And that's obvious at every single table. I saw people talking about the work they're doing or the work they could do together. And there's no, when we chose the name of the Health Collaborative, it says exactly what we do. We collaborate. And it also fills my heart to know that the collaborative is almost 30 years old. And I think I've been involved for probably 27 of those years. That's how long I've been at Methodist. Right? And I see people like Kevin Moriarty here, who I know, although he wasn't part of the first founding members of the collaborative, he was soon to follow. But I want to thank Christus Baptist University and Methodist, who founded the Health Collaborative simply as a way to collaboratively work on a community health needs assessment, or CHNA, as we fondly call it. So now we're on our 11th CHNA. And it's just incredible to me, and those of you who have been here from the beginning and who have been on this journey are probably just as proud as I am right now. So I want to thank a few folks for a minute. Please indulge me. The board of the Health Collaborative, who I think just about every board member is here today. Thank you for all the work and dedication that you've done. See now, Laura, you and your team, and you'll see in just a second, the mayor said we need data. Health Collaboratives got the data. We should get shirts that say we got the data. Also, where's Nino? You led the charge for all of us from the board perspective, and you'll be presenting along with Laura in a minute. Thank you so much. But more importantly, Elizabeth Lutz, our fearless leader. She has led our staff. Where's the staff? Everybody with the collaborative shirts. You are, big thank you to you all as well, because you've been in this together with us. So, I got to say, the mayor said half my speech, so thank you. But what I want to emphasize is the fact that we do this as a gift to you all. It is a gift to the community. It is a gift for y'all to use But please, when you receive that gift, do something with it. So as we go through the data, as we show you what's ailing the community, as we show you what should, what we should look like, and you all need to, we're going to give you the data, and then you all come up with the game plan. And we'll do it together as we put the chip together, but you can also do it independently in your own organizations. So just thank you again for being here. And thank you for your leadership and your dedication to the health and wellness of our community. But mostly, thank you for your passion.
I can't believe it's already been going on 30 years. So a quick fact, I was talking to someone yesterday and they asked, well, how do you know? How can you make sure that the information's right? Stuff went missing at some point. And I said, you know what? We've got some really great stewards of data. We've been partnering with Dr. McKieran's group for at least 4 assessments, right, Laura? Prior to that, we were working with many other community stakeholders, but we leverage every single piece of information that's provided. And we have wonderful partners like United Way, Area Foundation, CNOW, our hospital partners, our city officials, our county, and all of these people have been amazing stewards. And so the report that you see here today is a combination of all of that inventory of data, inventory of resources, inventory of partners that are coming together. So we stand behind this information. And we thank you so much for continuing to utilize the resource. So next up is the heart of today. We're going to talk about our key findings from the 2025 CHNA. I want to ask you to please help me welcome Dr. Camerino Salazar, our Board Secretary, Treasurer, and Data Committee Chair, and Dr. Laura McKieran, Executive Director of CNOW, Community Information Now, and Associate Professor at UT Health School of Public Health.
Okay. Well, good morning, everyone. Can everyone hear me? Am I clear? Okay. I'm not very comfortable being in front of large crowds, so please bear with me. But again, I want to begin by first a good morning to everyone and for just a great opportunity to talk about today's findings. I've been an advisory board member on the Community Health Needs Assessment since 2006, when my boss at the time asked me if I could sit and be part of the collaborative, and it forever changed my life. And so I want to acknowledge Teresa de la Haya for being that individual who really connected me to the Health Collaborative. It's been a wonderful journey so far. So again, as chair of the Community Health Assessment Data Committee, I want to begin by acknowledging that this moment represents much more than the release of a report. It reflects how far we've come as a community and how we continue to listen, learn, and act together. The assessment represents the work of so many: the Health Collaborative, Community Information Now, our hospital, academic, and public health partners, community-based organizations, foundations, policy and government leaders, and the residents, especially the residents who lent their voices, time, and stories to help author this report. As someone who works closely with data and primarily in the community health needs space, I always like to say that data is not just about the numbers, it's about meaning. Behind every data point is a person, a neighborhood, and a story of resilience or need. Data helps us see where progress is being made and where gaps still persist. It helps us to move beyond assumption to action, and it reminds us that our responsibility is not just to collect information, but to use it to create change. So I share this very same sentiments that Pal just gave and the mayor, right? We're going to use this information in the work that we do every day. It is vital. And again, the findings you'll see today and in the report itself provide a high-level overview of the state of health in Bexar County. They share data-driven insights, lift up the voices of residents and community partners, and emphasize collaborative, community-centered actions that strengthen family well-being, prevention, and resilience. Across every data set, one message is clear: we are still recovering. emotionally, financially, and socially. From the disruptions of recent years, many families continue to experience the weight of mental health challenges, housing instability, and food insecurity. But we also see hope and determination, communities organizing, neighbors supporting one another, and organizations aligning their work towards shared priorities. However, this CHNA is more than a report. It is a tool for alignment. Again, to echo the mayor's sentiments, it provides a shared foundation to guide investment, shape policy, and strengthen collaboration across sectors. In many ways, it's both a mirror and a map, reflecting where we are today and pointing us towards where we can together. Our collective challenge now is to ensure that the data does not sit on the shelf, or in a virtual shelf for that matter, but lives in the decisions we make and the partnerships we build. The real power of data lies not in what it tells us, but in how we choose to respond. Next slide, please, if you would mind. So before we jump into the 2025 findings, I just want to take a brief moment to briefly look back. 10 years, I think, is generally a good mark to pause and reflect. And I found myself reflecting as I was, drafting these opening remarks, thinking about our 2016 Community Health Needs Assessment. We can't revisit every detail, but in the interest of time, I just wanted to share a few things that stand out, some signs of progress, and some reminders of the work that remains. So again, the next slide captures that journey, or is intended to capture this journey. A story told in 3 chapters: how we've grown, what has improved, and where our challenges persist. Over the last 10 years, Bexar County has grown by more than 200,000 residents. We've become more diverse, more multi-generational. Nearly 3/4 of residents now identify as people of color. And although still generally young, our population is aging. And so as our community grows, so does the need to respond to the shifting health needs. We've also seen progress, and I think this is extremely important. Oftentimes in the work that we do, we never just pause, right, to appreciate the milestones that we made, the progress, right? We go back and we're working daily and we're, putting in this passion that we have, but yet we never pause to reflect and say, look, there's some good work that we've done as a community. Health coverage has strengthened, with about 85% of residents now insured. Teen birth rates have dropped sharply, and more residents are earning college degrees, a foundation for long-term stability and well-being. Partnerships across public health, healthcare, philanthropy, education, and local government have deepened, strengthening the ecosystem that supports community health. Yet challenges persist. Housing affordability remains a major stressor for families. Mental health needs have increased, and chronic diseases like obesity, diabetes, and heart disease continue to affect too many of our neighbors. These issues remind us that progress and persistence often coexist, that our collective work must continue with the same focus and result that brought us here today. Again, each chapter represents not just a data point, but the collective work of our partners and our residents. It's a reminder that progress in community health doesn't happen all at once. And it's through shared effort, persistence, and purpose that it's most meaningful. So again, as we turn to the 2025 findings, let's keep this in mind. Behind every number is a person, behind every chart is a story, and behind every change is the collective action of a community determined to do together and better our community. And with that, I would like to extend my gratitude to all our partners and participants. It is great to see everyone today. And to each of you here today for being part of this ongoing effort. Together, we can use this data not just to describe what is, but to help build what can be. A healthier, stronger Bexar County where every person has the opportunity to thrive. With that, I will turn it over to Dr. Laura McCurran, who will guide us through the findings.
Good morning. We got a great crowd this morning. Thank you all for being here. There are a lot of folks from our world here today, so I just want to take a second to apologize to all of you for not having emailed you back yet. It's been a wild few months. So yeah, I'm executive director of community information now. We're a local data intermediary. For those of you who don't know us, our entire job is to put data in the hands of people who are working to improve community conditions. And for those of you who are in the healthcare world, you might have heard the term the right care by the right people at the right time. And we try to bring the right data to the right people at the right time. You're the right people. Thanks to the Health Collaborative for continuing to partner with us. We are bringing you the data. We have been staffed through a partnership with the UT Health Houston School of Public Health in San Antonio, which is a 45-year-old well-kept secret since 2008. And we are a partner in the National Neighborhood Indicators Partnership. If you want to check out other folks that do the work like we do. I want to, before I go further, this is going to go all the way off the stage. It's going to be very exciting. Sorry, it's moving. I want to ask my team to stand up. Community Information Now team. We've got Jeremy Pine, Daniqua Forrest, Natalia Rodriguez, and Jeanette Barra. We are a tiny, mighty, tired squad. Okay, let's get going. Next slide. Yes, approach. So, all right. So, about 15% of you are hardcore data geeks, making up that number, and want to hear a lot about how we did it. But I'm guessing the other 85% of you would be okay if I kind of breezed through that a little bit to make room for the panelists. But there's a table in the report that has a summary of all the different representation that we had in the assessment from various perspectives. And I encourage you to check that out so that you know that it's not just our team bringing you the existing data, but a lot of different folks participated, and a huge thank you to the Health Collaborative staff for all the work that they did and the perspectives that they bring. Next slide. We went through an extensive process for the 2019 CHNA to choose indicators, and we have continued to build from that rather than reinventing that wheel. So we just updated the list with what was newly available or no longer available. And so a similar report flow to 2019 and 2022, but we tried to be a little more positive this time. Our field is very, very good at identifying problems and measuring them, and not so good at identifying and measuring assets and strengths. That means you're going to see some charts that are a little oddly worded, like percent of people who have never been told by a healthcare provider that they have depression. So just know when you read that there was a reason for that. We were trying to show how the ways that we're doing well. Trending, disaggregating every which way. There's a whole lot more data available at Bear Data Dive online, dive.cinow.info, if you don't see the bar chart that you wanted. Next slide. I can skip through this, I think, but just to let you know that it is a hefty report. Sometimes I like to joke that we get paid by the pound. The introduction and summary up front has the basics of how the assessment was conducted, and then a summary of shared and differing priorities across all the different folks that we talked to. And then Appendix A is, if you're into the qualitative, it's the full narrative summary of themes that came out of the key informant interviews and focus groups and so forth. And then some more nitty-gritty notes are in the technical notes, methods notes. Next slide. So again, we did do a ton of extant data, about 100 indicators, 95. Did a convenient sample community survey, focus groups in English and Spanish, and key informant interviews. 46 total participants across the focus groups, and not a great survey response. We're having this experience everywhere, and I'm hearing it from other folks too. I think people may be a little bit surveyed out. But we did get 141 folks. Next slide, please. That are, yeah, let's just skip past this bit. We did stuff. We analyzed it. Fairly actually representative of the county in terms of race and ethnicity, but as is always the case with surveys, women talk and men don't. Very disproportionately female. We do have a fairly good representation of folks who are living with a disability or affiliated with the military community, which I think is important. Next slide. I'll skip through the details of this, but again, we talked to folks in English and Spanish. Thanks to the Health Collaborative for the logistics on those. All we had to do was show up to that party and facilitate. They recruited the participants for us and set up the venue, which is a tremendous amount of work. Next slide. Key informant interviews. We talked to about 6 folks, lasting 60 to 90 minutes each. And then we took all of it was analyzed separately, the key informant interview and focus groups, but all of those transcripts were AI automatically transcribed by Zoom, as I'm sure you have seen, and then reviewed by a human. So I want to stress that, and analyzed in Atlas TI for themes that were common and different across the groups. Next slide. Yeah, lots of, we had X charts and maps and Y data points. Apparently I was going to count for y'all. It was a bunch. Sorry about that. Next slide. It took a year. That's the point of this slide. We did Bear, Atascosa, Comal, Gillespie, Guadalupe, and then Create Healthy in Gillespie County asked if we could just tack on Blanco, Llano, Mason, and Comfort. And we were like, it's June, but sure. And that was probably where everything went terribly wrong. Next slide. So what stands out? What you heard from the groups is different kinds of folks that we talked to is, of course, largely a function of what questions we asked and how we asked them. So I want to encourage you not to compare directly across groups in a table to say, that if there's not a little dot indicating that theme came out of one of the different forms of community input, that it wasn't important to them. It might just be that the conversation went off in this direction, or we didn't specifically ask about it. But for sure, we see agreement across all groups that we've got a lot of vulnerable people, disparities and inequities, and there was a lot of agreement about older people, youth, and racial and ethnic minorities. And then also folks who are unhoused, formerly incarcerated, or have other criminal justice involvement with substance abuse disorder. And then, of course, we know we have tremendous geographic disparities. In Bexar County, we're still one of the most income segregated communities in the country. And there's a lot of concern, unsurprisingly, about funding and how funding is affected by politics and government at the same time that community residents are losing various benefits and facing inflation at the grocery store. The organizations that serve them, many of whom are in this audience, are facing funding cuts. And another theme that came out, and it's not necessarily actionable, but it's certainly true, that COVID-19 really changed the landscape of how technology is used, expanded the use of telehealth and remote work, for sure. Next. And the report is divided into 4 sections. The first is basic demographics, and the second is what we need for health. All of those upstream factors that determine how hard or easy it is for us to make healthy choices, what resources are available to us. And then the next section, how we're taking care of ourselves and each other, I would add, but that kind of didn't fit on the page as easily. So, the health-related behaviors, the screenings, the exercise, things like that. So those two sections are collapsed for priorities here. Food security has come out big in every single county that we've looked at, every group that we've talked to in every county that we've looked at. And it has taken some folks by surprise. Mental health is another one. Obviously, we'll get to that later. Housing availability, protection from extreme and hazardous weather, access to health care, insurance and medical costs, and provider shortages, even though we're in a large county, large city, and our provider access is a whole lot better than a lot of the surrounding areas. The starred indicators there, food security and housing availability, are priorities in the community health improvement plan. Just wanted to point that out. Next slide. Oh boy. What's easier to read? Okay. We'll just trust that I have all of these memorized. I'm at a funny angle. The chart on the left is from community survey data. They both are from community survey data. And the dark blue bar is percent of respondents who indicated that something was a priority for their the health of them or their loved ones. Having it, whether they currently do or not. And then the lighter blue, brighter blue bar is percent of respondents who indicated that it was a priority, who then say they have pretty good or very good access. Looking at the top view, healthy, fresh foods, outdoor green spaces, stable employment, clean air and water, quality mental health care, safe spaces to exercise and be physically active, connections with people they can count on for help, and quality medical care. And you'll see that only on the environmental indicator or the environmental priority and connections that people can, are you going to let me roam? It would make me so happy. I do better this way anyway. Connections that people can count on for help when they need it. Those are the only two where the percentages of people who said that they had it were greater than the percentage of people who said that they needed it. So big gaps on some of the others. And then the next slide is percent of, oh, sorry, I meant next chart. I said the wrong word, sorry. Percent of survey respondents reporting always or often getting the care that they need by type of care. So doing pretty well on prescription medicine. And then unsurprisingly, in-home health assistance. That's the lowest percentage, that bottom bar at 31%. But mental health care, not much better. Next slide. And this is food insecurity, percent of population that's food insecure. This is not survey data. This is from Feeding America. And you see a big uptick. I think that's probably the inflation post-COVID that you're looking at there. And then percent of population food insecure by race, ethnicity, much higher percentages in our Black or African American and Hispanic populations than in our non-Hispanic white populations. Next slide. So percent of population with income. The darker blue bar is households under the Census Bureau's definition of the poverty level. And then the lighter blue bar is ALICE. And for those of you who are not familiar with ALICE, it stands for Asset Limited, Income Constrained, and Employed. And it's a measure that's come out of the National United Way network, actually, to try to capture all those folks who are working and above the poverty line and ineligible for benefits most of the time, but not making enough to get by on just the basics. So not enough to meet the survival budget. And you can see that we we're making a little bit of progress. The fact that the percentage is going down means that we were making progress, but I think we're going to see that tick back up. Wages are not keeping up with inflation, for sure. Mayor Jones already alluded to SNAP benefits ending. That second chart on that page is inflation adjusted SNAP payment, average payment per eligible individual. So you'll see that that payment has been going up, but the darker blue line beneath that is the number of people that the benefits are going to per 100 population, sorry. So fewer people are getting those benefits, and I think that's probably going to continue to be the trend. Next slide. Okay, the slide on the left is percent of households under 200% of the federal poverty level that are housing cost burdened. We have owner occupied on the top and renter occupied on the bottom. And those horizontal gray bars that you may or may not be able to see are the margin of error on these estimates. So just a word of caution that some of them are pretty wide, and it makes it difficult to compare among groups. But obviously our renters are much more likely than homeowners to be housing cost burdened. And as might be expected, our Black or African American renters and Hispanic or Latino renters are much more likely to be housing cost burdened. We don't see quite that same pattern in the homeowners. We've got kind of a bifurcation in that population. The chart on the map on the right is a measure that I will fail to explain except to say that this is heat disparity. Think of it like that. Relative differences from the average. Red is hotter than average and blue is cooler than average. And this data comes from Dr. Kristen Brown at UTSA. Are you here? Waving, thank you. There is no heat data. So I was so delighted to discover that Dr. Brown has been working on this issue, and I hope we can continue to see more data because the effects of heat are tremendous. You can see there's a very dark red area kind of up the South Zamora corridor up to Highway 90 and down to maybe about 410, and then, you know, spots elsewhere. People who cannot afford air conditioning are more likely to live in these areas too, compared to the north side, of course. And we're going to see, I think, increasing problems with this going forward. Next slide. Percent of, okay, so this is percent of civilians who are insured. There's a vertical gray line through all of those bars that represents the county-wide percentage, and it's 85%. But as I'm sure that you know, insurance, percent of people insured varies dramatically by age group and by race ethnicity. And this is another measure where we can expect it to get worse. Kaiser data, I looked up some before this presentation. 95% of Texans who have bought a policy through the marketplace are getting help on the cost of premiums through Affordable Care Act cost tax credits or cost sharing reductions. And those tax credits are going to expire at the end of the year. I know SNAP benefits are on folks' radar, but I don't know that those tax credits are. So the cost of premiums is going to skyrocket. And if you look at the chart on the right, still the greatest percentage of insurance is employer based. That's that yellow line up at the top. And we see it, we're missing data for 2020 during the height of the pandemic, but you see that it starts to rise again as folks are connected with jobs. But those folks are not sitting pretty because those premiums have risen 6% over the last year, employer-sponsored premiums on average, which is faster than wages or the general inflation rate. Next. So how we're faring. This is survey data. Percent of survey respondents rating their mental health in the past 3 months is good or very good is the left chart. And on the right is connections with others. There's a funny dynamic with the prefer not to answer group that they fare worse on a number of measures, actually in all the counties that we looked at, including Bear. I did notice an interesting pattern in the social connections with others that we see a lower percentage among the Black or African American population. And my best guess is that that is at least partly a function of the fact that a larger percentage of Black or African American residents have moved here from out of state in the past year compared to Hispanic and non-Hispanic white residents, 7% versus 2 among Hispanics and 4 non-Hispanic whites. So social connections fare a little bit better than mental health, but mental health is again a thing that we saw all the way through the report. Next. Top health issues we saw. Again, depression, anxiety, PTSD, chronic stress, top for both female, which is the chart on the left, and male on the right. Diabetes, chronic pain showed up as a high percentage. It is number 3 for women and number 4 for male respondents to our survey. It showed up in every county that we looked at. And as people have asked me where that came from, it hasn't really been on our radar. I think that it's that we have never asked. We had a formidable laundry list of health issues in this survey that people could select as affecting them or their loved ones. And I think it's that we gave people an opportunity to report that. And what it is, I'm sure varies by population. It could be like workplace injuries among younger people, fibromyalgia among women, and arthritis among older people, but a big deal. And I'd also just like to point out that you see the bars are wider on the female chart. A greater percentage of females, you see that differently. Among females, they were many more people selected issues. So a longer list of issues per respondent than compared to males. And next slide. So I really struggle. It's my least favorite part, actually, of this whole process. How do you winnow down 250 pages into just a few key messages, especially given that strengths and challenges that people are shouldering vary so dramatically by community, by population, by area of the county. These felt like safe. Nobody could argue with these. Definitely not recovered from the COVID-19 pandemic, economically, psychologically, and given the prevalence of long COVID, I would say physically. A large proportion of the community is suffering mentally and emotionally, whether diagnosed or not. And then basic needs and root causes. I think these have always been a bigger player in San Antonio with our poverty rate, but it's worse now than it has been. And we've got to address those basics like food and housing. I was analyzing Health Collaborative Pathways Hub data this week, and the number of people who needed help with clothing and diapers, baby items, basic household items was just through the roof. And I don't know that we are, that we really see that as clearly as we should at this point. So I think that's all I have. And no, there'll be no questions. There'll be no questions. There'll be questions later. I would like to say, we have 5 sets of eyes on the data, plus whatever our talented designer caught, but we welcome hearing, that we messed something up. I mean, we're not excited, but we can always revise the PDF online. So if you see something that looks wonky, please do get in touch with us. And we would be very happy to look into that and fix it if needed.
All right. Thank you, Dr. McKeon. Thank you, Dr. Salazar. Thank you, CNOW, again, for being our research partner and our data intermediary. If you do not know CNOW, you should. Please connect with them. They are a wonderful asset in our community. And as Laura mentioned, we are absolutely thrilled that we have a PDF report. We have a limited number of copies. Thank you, Methodist Healthcare System, for being the provider of those printed reports. But we have the virtual version as well. So I want to make note, Laura referenced that we were able to do a much larger amount of CHNAs this go around. We started with expanding into Atascosa, again, thanks to the partnership with Methodist Healthcare System. And then through the partnership with Christus Health, we were able to provide now a needs assessment into the Comal community. So thank you, Christus, for that additional investment and providing us the opportunity to expand. And then beyond that, we also were provided some additional resources to conduct the Gillespie County needs assessment. And that became a lot larger, as Laura mentioned. Atascosa, Guadalupe, Comal, Medina, Gillespie, Kerr. These are all communities that are still connected to Bear. And we are the Mecca for a lot of resources. We see that in our data. We see that in our care coordination data all of the time. People that are coming into the county for services because the rural opportunities are not available. And so this time around, we were very excited that again, we were being trusted with the chance to provide a quality and a comprehensive report into these other communities. Guadalupe is coming up here next. So on the website, you will be able to download the report today. Others are available, and we're respecting the release of each of these community reports into those respective communities. So you'll see the others open up as we continue our journey into November. So again, we welcome your feedback. And of course, we welcome an opportunity to enhance the user experience for you in whatever means you are able to access the report. All right, so now we're going to move into community solutions. We are now shifting from the findings again to solutions. And so with that, please help me welcome our moderator, Ms. Teresa de la Haya. She's our retired board emeritus member, and our panelists, Dr. Andrea Guerrero, Dr. Lisa Ochoa, Gedalia Ramon, and Dr. Jenda Wu. You're welcome.
Good morning, everyone. I was wondering what photo they were going to use of me after you're retired almost 3 years. You're almost afraid what photo is going to come up. So thank you, Liz, for making me look half decent here. I'm actually a founding member of the Health Collaborative. 30 years ago, I sat at Santa Rosa with Sister Michelle, myself, Greg Crabtree from Methodist, and Jean Setzer. And 30 years ago, we talked about how we could work with one another to really enhance our efforts towards finding solutions to what the community needs were. And we also, as a health system, each one of us had to do our own individual needs assessment. It was a requirement. And we thought, wow, why are we doing this individually? Why can't we come together and work with one another and have a bigger impact in our community? And thus, here we are. But when I think about 30 years ago and I think about today, If I had a picture of 30 years ago and a photograph of today, I have to say I'm a little disappointed that we haven't gotten where we need to be. We've been working hard, and it's not because of people's efforts haven't gone unnoticed, or how people have really tried. Funding, policy, all of those things have impacted everything that we have attempted to do, and we have some setbacks now, and we've got to talk about those setbacks. And even more today, it's much more important that we work as a community. And San Antonio is known for that. We're known for coming together in almost every aspect and working together. And so for 30 years, I've seen the needs assessment data shared with our community. But today, we're going to move a little bit forward and put the providers, the individuals who are making tremendous impact in our community, city, county, healthcare providers, social providers who are out there doing the work. Let's hear from them and let's see what we can do, what is working, what's not working, and how can we come up with a plan? Because CHNA, it only works because of you. This data can sit in a closet or can sit on a shelf, whatever the case may be. But today we're going to talk about how we can move it forward. So with that, I'm going to introduce to you our distinguished panelists. Let's start with Dr. Andrea Guerrero, who's the Director of Public Health for Bexar County and long-serving board member of the Health Collaborative. In response to the COVID-19 pandemic, the Bexar County Public Health Department was created in 2022 to build capacity and coordinate county resources to support public health efforts for all of Bexar County. She has served her community in hospital administration, higher education, community-based, and public health, and as an independent consultant in the areas of evaluation, leadership, strategic planning, and nonprofit operations. Please help me welcome Dr. Guerrero. Then we have Dr. Lisa Ochoa, who's a board-certified vascular surgeon and founder of the San Antonio Vascular and Endovascular Clinic, which is called SAVE, and Mission Surgery Center, the only Medicare-accredited ambulatory surgery center on San Antonio's South Side. Dedicated to reducing diabetes-related amputations, she combines advanced surgical care with community-based interventions to improve outcomes in underserved populations. Dr. Ochoa also serves as the founding chair of the Center for Health Empowerment in South Texas, which is called CHEST, and president of the Cass Schools Board, leading cross-sector efforts to close life expectancy gaps, expand health career pipelines, and address social determinants and non-medical drivers of health. So again, please, let's welcome Dr. Ochoa. And then we have Mrs. Ramon. She's a director of social determinants of health for family services. Ms. Ramon is an ambassador of the agency's mission while propelling the service delivery, a framework aligned with social determinants of health through a trauma-informed lens. Within the healthcare industry, Ms. Ramon has implemented innovative programs across the country, and particularly right here in Bexar County, connecting patients to vital community resources, reducing ER visits, and strengthening primary care relationships. Her strategic leadership has expanded cross-sector partnerships, secured sustainable funding, and fostered a data-driven culture to enhance community impact. Her experience in community engagement and the mental health field reflect a deep commitment to empowerment, education, and culturally responsive service delivery. Ms. Ramon brings several decades of experience building bridges between healthcare, social services, and community-based efforts. Let's welcome Ms. Ramon. Then, we have Dr. Wu, who works with the Metro Health District. And Dr. Wu serves as a medical director, a local health authority, and an STI and a TB clinician at Metro Health. She oversees the Center for Policy and Health Improvement, whose portfolio includes the Health Equity Network and the CARE Initiative to create responsive Black maternal and mental health care. Trained as an obstetrician at Bader College of Medicine and with a master's in public health from the UT School of Public Health, and joined Metro Health in 2015. An interesting fact about Dr. Wu, in her previous career, she was a reporter at the Wall Street Journal. So with that, we just thought we'd throw that in there, Dr. Wu. So with that, we have 6 questions for our panelists, and I will ask our panelists to respond to those questions. Now, if any of you feel like, hey, please include me on that answer, please feel free to respond appropriately. And Liz, you keep me on time here so we don't go over time. So our panelists have come together with twofold objectives. One is to translate CHNA findings into clear, practical actions for agencies, for payers, and community partners. And secondly, we want to highlight cross-sector coordination between clinicians, public health, the county, social care. And so we hope to achieve that this morning. With that, let me ask the first question. And this question will be addressed to Dr. Ochoa and Dr. Guerrero. So we want to know what's working today. So from your perspective, what are you currently doing that addresses one or more of the CHNA priorities, food insecurity, maternal and infant health, behavioral health, whatever area that you're working in? And what early results or signals are you seeing today? Dr. Choi, you want to start?
Thank you. Hear me?
Did it work?
Okay. Thank you for having me here. I have to say it's quite an honor to sit on such a team panel, especially with a wow. So I feel like I wear 2 hats, maybe more than 2 hats as I sit up here. And one of those is as a physician, a surgeon, a vascular surgeon that practices in the most underserved areas of San Antonio. And I feel like I'm kind of in the grassroots of seeing the results of we see data, we're seeing numbers, but I'm seeing the patients. In my office, I see patients, and you saw one of the high things is chronic medical conditions, diabetes, obesity, high blood pressure, high cholesterol. And I see them related to the blood flow to their legs, to their brains, and to their heart. And one thing that I have seen is that the mental health and behavioral health is becoming more of a burden. I am not a mental health provider, but I see my patients suffering from these. I am fortunate that I know a lot of people in this room, and when I do encounter patients like that, I begin to try to pair them with what resources we have, and I'm grateful, and the things that we're doing well is that we do have resources. And the magic is, how do we connect the person to the resource directly? And I think that's where a place we can do better. As the other hat I wear, I am the chair of the Center for Health Empowerment in South Texas. This is a new 501c3 that is addressing the health disparities north and south of San Antonio. It's a cross-sector coalition, bringing every sector from public health and healthcare to education, workforce development, and then everything else, housing, food insecurity, environment, and figuring out how we bring leaders together to make impactful changes, impactful collaborations, and partnerships to address the fact that lifespan varies 20 years north and south of San Antonio. And I have to introduce our inaugural CEO, who is here today, and that's Dr. Adriana Rota Garcia, and we have a board member here too, Jean Rodriguez. And I have another board member sitting next to me, and someone else who's on the board. So, but one thing that we decided with CHEST, and that's what it's called, CHEST, is that we really want to figure out how do we partner with boots on the ground, people already doing things, and how do we make things better? And just one small example of how Trust is trying to really integrate and getting to the people is we have partnered with UHS and the student-based clinic, and we're starting a pilot program to figure out how do we get those patients that are seeing the community-based clinic and begin to survey them and get them the food that they need. Health is food. I can't tell you when I see my patients and they ask, what is the thing that I can do other than take my medication? I said, what's better than medication is the food that you put in your body and exercise and activity. Those are the two most important medications that you can do. And when I say this to my patients, I can tell you that a lot of them are struggling. So we're trying to figure out not just how do we create opportunity for food, but how do we get it into their hands specifically and see how that actually changes outcomes. So hopefully more to come on that front.
Thank you, Dr. Cho. And how many surgeons do you know are worried about food insecurity? I think she's the only surgeon I've met that talked to me about food insecurity. She's a great example of what we need out there in the community, from the outreach worker all the way to the surgeon coordinating services. So thank you for doing everything that you're doing. It's wonderful work. Dr. Guerrero.
Thank you. Proud to be a board member and being led by this visionary here. And I was also once profiled in the Wall Street Journal. It was many years ago. I had a hot dog business. If anybody wants to hear the story, I've lived many lives, but hot dogs. I'm obsessed with hot dogs. In moderation. I want to take care of my peripheral nervous system. Cardiovascular system. What's working? So as it mentioned, I'm about to celebrate my 3rd anniversary at the county, and I am the first director of public health for Bexar County, which many people don't believe, because there wasn't a public health department at the county prior to the pandemic. And, Metro Health was doing a spectacular job, but the pandemic sort of revealed that there needed to be that function in the county government as well, especially to take care of folks in the unincorporated areas. So I'd say from that perspective, what's working, I think, internally at the county is that we have had a shift in taking a public health approach to many of the functions that the county has, primarily in creating my department, in taking over the behavioral health division from the Office of Criminal Justice and moving it into public health, which doesn't seem, operationally it looks kind of the same. We're still operating in the jail. We're still, partnering with folks in substance use and mental health, but really looking at it from an upstream preventative approach and looking at how mental health and behavioral health impacts our community. And it's not just an individual level problem, but it is a public health problem. That it just the shift in perspective in the lens, I think, changes a lot. Hi, Carol. So I would say doing that, and also, things like code compliance and animal control, which is one of my divisions. The deeper we dive into, for example, some like high profile seizures of lots of, when we have like 80 dogs in one place, or code compliance where folks are not removing trash from their front yards and then they rack up lots of failure to appears and they become part of a criminal justice or a civil citation system. When really at the heart of those issues is mental health issues, right? The inability to cope, lack of money and resources to clean up their yards. And so things that are just sort of as mundane as illegal dumping can sometimes really reveal a behavioral health issue. Veterans, our veterans director is here, Keith Wilson. Yes, there he is right there. He, and we work closely with them to, and they have, veterans has social work staff, and they go out and help folks with homelessness issues. And so there are a lot of things that are happening at the county that just really a different perspective at looking at them and how are we approaching solutions, how are we partnering with our city partners and with nonprofits, and really looking at how can we be a convener. We obviously are a funder, and really not necessarily building our own tables, but how do our teams go sit at your table so that we can understand what is working, because you all are doing the work, but how do we support that? So I think really just having a shift in that way. And then to piggyback on that is the collaboration, right? Jesse Higgins is here, one of the chief mental health officer for the city of San Antonio, who is an amazing partner. But we both sit on the Southwest Texas Crisis Collaborative, which is organized and sort of convened by STRAC, but every hospital system sits on that committee, the LMHA, city, county, who else? Like universities, philanthropy, everybody. I mean, we can name, but basically anybody that's touching the behavioral health sphere, and especially the hospital systems, because they will tell you, I mean, I wasn't there on this committee back then, but they will tell you that it took days to find a psychiatric bed, days for someone sitting and suffering and waiting. And because of the organization and because of the sort of backbone of having STRAC as that partner and convening those partners and those people sitting at those tables, and having hospital CEOs understand that a financial investment is important. You know, all of us that pay dues into that crisis collaborative so that it can operate and gather data and show that return on investment. It's really that collaboration that has made the difference to where we can tell you where there is a psych bed available right now, you know, for the next person that goes into an emergency room. So that kind of collaboration, the new collaboration with CHEST, the health collaborative, you know, I think that was kind of like the OG of collaborations. I think those are the things that are working because we are all doing these things but we have to sit at tables, right? And it's sort of like a metaphor. We're all sitting at tables together today, you know, food bank, grandparents raising grandchildren. Hi, Mitch. Yeah, doing amazing work. And how do we continue to make these connections and collaborations and things that maybe aren't so intuitive, like vascular surgery and food insecurity, which we all understand, but not everybody makes those connections. So I think those are the things that are working. You know, we're only 3 years old at the county, and ARPA's ending soon. So we still have a lot of lessons to learn from the folks that we invested in with ARPA dollars. Opioid settlement dollars are yielding results as well. But I think those are the things, you know, it's just really kind of like feeding that information back into the loop and the learning loop, and then, you know, continuing to improve.
Thank you, Dr. Cho. I know that a lot of people know that the county has this new public health department, but I don't know that a whole lot of people know what that means. And so I appreciate the opportunity that we have today to share with you some of that information, that some of the things that are working, and with the things that Dr. Cho are doing with the CHEST and other things that are going on. These are very, very hopeful areas where we can hopefully collaborate a little bit more on and get a little more tread and maybe make some difference in our results from the that we just shared with you on the needs assessment. So let me go on to the second question. And this will be for Mrs. Ramos and Dr. Wu. Where are families still falling through the cracks? If you could name one bottleneck, maybe a policy, a process, maybe an eligibility requirement, transportation, that keeps people from getting the help that they need, and what do you think could fix it?
Good morning. So many to choose from. I'm going to stick to my notes so that I don't go off into a tangent. And it's freezing in here, by the way, and I'm from Chicago. And it's still very cold. So many to choose from. Eligibility is a barrier across the board. Let's take trying to access transportation for a patient. In our SDOH program at Family Service, where we partner with UHS, and my respected and esteemed partner, Sarah Muhammad Ali, is here from the Institute of Public Health. You can clap for her. She deserves it. Our team, our SDOH case managers meet the patients in their home during the initial intake and assessment. This eliminates the first barrier of getting to our office. Let's say we assist the patient with filling out a via trans application. Patient has to take it to their doctor's office to get the document signed. This is oftentimes a problem if the patient is too sick to go, has no family friends to support or drive them there, or doesn't have an address and is homeless. This application takes at least 21 days to process and requires a return address to send a letter of acceptance. Or how about SNAP, where one of our disqualifiers for many of our families is the fact that they own a car valued at $22,000. In addition, if someone else in your household owns a car valued at more than $8,700, you are not eligible. What in the world Does that have to do with the fact that you need supplemental food for your family? Nobody answer. It's okay. Due to the fact that many families are living in one household, they will naturally need more than one vehicle. Public transportation is severely lacking in San Antonio. I'm from Chicago, remember, especially the further away from the downtown center you live. So the system punishes you if you don't have a mode of transportation. We need to rethink our qualifications from the lens of the person applying for the assistance. We, the people in this room, need to find ourselves at the tables with people who are creating the eligibility requirements. We cannot afford to remain in our silos. We all need to create and maintain relationships with people outside of our disciplines. I believe this is the only way that real change is created. It's when me and someone from American Heart Association like Raquel de Hoyas runs a program that allows vouchers to get to people all the way by Lackland Air Force Base. It's those connections that bring Brussels sprouts and asparagus to my patients on Medina Base Road. Let's start somewhere. Just have coffee with somebody outside of your discipline. That's my challenge to you.
Thank you. I appreciate that. Everything you said, I think needs to be underscored 1,000 times. Thank you for sharing. Dr. Wu.
Yeah, thank you for bringing up a lot of the things that I had in mind. And then I'm going to take a step back. So you really made it personal. And if you take a step back, it's not just SNAP, right? It's also what happened with Texas unenrolling more Medicaid and CHIP recipients than any other state. For SNAP, Texas has this rule that if the head of the household is not eligible because they're not meeting some requirements, then the whole family becomes ineligible. There's having to re-enroll for CHIP and Medicaid multiple times a year to re-prove your eligibility. And if you have kids who, I'm going to have an addendum to this, but it used to be that if you had kids who you signed up at different times of the year, they'd be on a different schedule. And so like if you had 3 kids, you would be just spending all year reattesting to your income, right? It is at base a system that is hostile to a safety net, is a system that treats poverty as, it perpetuates the illusion that poverty is some kind of a character defect instead of the outcome of a series of limited choices that were forced upon you. And there are 2 ways to deal with that. One is actually that vehicle asset tax that you're talking about with SNAP. A lot of people, some of the policy people in this room know that the food bank went to the mat to try to change that a few sessions in a row, and last legislative session did make some changes. With the enrollments for CHIP and Medicaid, that got changed one legislative session ago to only having to re-enroll twice a year. So there can be changes made when we get together at a legislative level. And then in between, what about until then? I think the answer is in community. It's in what we're all doing together.
Thank you, Dr. Wu. Appreciate that. Due to time, I'm going to skip around a little bit here so that we hit some of the main questions. I'm going to address this question to Dr. Guerrero and Mrs. Ramon again well, maybe not. Let me address this to Dr. Ochoa and Dr. Wu better yet. If you look at a 90-day action and a resource ask, what one action do you think you can engage in over the next 90 days, and what single resource or decision would help you?
Well, I think a few different people from the mayor on have alluded to the fact that Metro Health is going to, be working with the Health Collaborative and take a larger role in the CHIP this year. And so what would help, and there's a little card in your packet that looks like this that explains our new Center for Policy and Health Improvement that is going to lead that work. For those of you, some of you in the room are working with as part of the Health Equity Network. So that's an example. And That team is trained formally in collective impact, in results-based facilitation. And so we try to get that implementation done. And what we could use is for everybody in this room to align, to use this chip as a vehicle so that we can all be moving in the same direction. And then the mayor mentioned courage. I'm going to ask people to be courageous in how we maybe look at some of the objectives and maybe reframe some of the objectives now that we have some different data, now that we're in different economic climates, to really look at that. Is anyone better off part of results-based accountability and how we're going to get to that?
Thank you.
I thank you for that. I think that using this chip and that we all have a role in making progress. I'm going to say immediately, it's not going to solve all problems, but November we open re-enrollment for health insurance. And I think we all know that if we don't have extension of the tax benefits, also the cuts to Medicare, Medicaid, that re-enrollment is intimidating to a lot of populations. And let's be real, there are geographic differences to who has health insurance, who has access to it. If anyone has tried to get health insurance for themselves on the marketplace, it is not easy. So CHEST is actually going to try to figure out how do we intercept what we believe is going to be a lot of people coming, not being uninsured, and create events where we bring community health workers, health navigators that don't just try to sell a plan, but are they actually going to sit with the person, talk about what their finances are, talk about what their health needs are, what their mental health needs are, because believe it or not, every different plan is different. If you have mental health needs, there's a certain plan for you. And get those right people to the table to figure out how do we intercept what we know is coming. And so we're going to partner with our city and county leaders to tell us what neighborhoods, what resources, what locations, how do we get the message out to these people it's going to touch. And I think that's the other ask that I have. Is my ask is everybody here needs to get involved in this kind of effort. We have a lot of programs, we have a lot of initiatives, but I feel like a big gap that we have is going to where the person is, where they are, and touching them person to person. And that means we have to go into their community, we have to go into their neighborhood, and that's where we have to help meet them where they are. A lot of our community, as we've heard, live lives of scarcity. They live lives where they're worried about are they going to pay their light bill, their house bill, are they going to get food? And really the last thing sometimes most of them think about is their own health, their visits to their doctors, and for their children. And so I think that in this next 90 days, this is the one thing that we can come together and make the most impact on to prepare our vulnerable populations for what's to come.
That's a wonderful point, because I think there's so many plans out there that want to enroll everybody into their plan, but I don't know that they're really evaluating which plan is best for that individual and family. There's a couple of individuals out there that are looking out for individuals and families, but not too many. So I agree with you. That is a huge problem. Thank you for sharing that. I'm going to go to equity focus, and I'm going to again ask you, Dr. Ochoa and Dr. Wu, which two zip codes or populations would you prioritize first, and how will you include community voice in shaping the solution?
Right. Well, my cheat code for that, I am an OBGYN, and our OB population is two populations, and not just people who are biased like me. A lot of people think that your maternal and early childhood populations are the most important ones, the most high leverage ones that we can be working with. And so another project that is going to be launching soon from the center is the CARE initiative, which is a different way of looking at how we can make healthcare more accessible, because it's a focus on maternal and mental health. And it's with a panel of community members, Black women and allies who have been working on this for, 2 years, thank you, SJ, for a long time, and on what's important to to them when they go see a doctor. So it could be, you know, what about price transparency? What about what messages do you get in the waiting room about how long that waiting period's going to, how much longer you have to wait? What about what kind of trainings do your staff get? So they've come up with this long assessment. Well, it's not long, but an assessment that we will be applying to mental and maternal health providers, and then sharing, showcasing the really great providers. And then for the ones who are not showcased, who want to maybe learn, get some tips, or do some trainings for their staff so that they can be showcased the following year, we're going to be providing that assistance. So that's an innovative way and very community-centered of improving maternal and mental health.
Great, thank you. Dr. Choa.
You know, what populations? Well, let's just look at the data. It's our South Side and West Side populations that that are the most in need, the most vulnerable. Not to say there's not in any other areas, but I do believe that we need to use this data to figure out where we use our resources, where we use our funding, and collaborate to make the most impactful change. And we do that by going into the most vulnerable communities. And those are the South and West Side. How do we keep community voice at center? There are a lot of organizations and nonprofits that are already grassroots working in San Antonio. This is a great thing we have in San Antonio. Our San Antonians love their city, love their neighborhoods, love their communities, and they are working to make them better. And I'll give you one example. Chest is actually partnering with South San to see if we can work on acquiring an abandoned school to bring a health empowerment zone to the Quintana corridor, which is South crossing Quintana and 90. And we're partnering with a Quintana work group of churches, small businesses, nonprofits, Puerto Unida, figure out how we bring a community hub in their community with resources and help with that economic development in that corridor. And we hope that this becomes a pilot program for how we do this in every other community, and we begin to empower from within.
Thank you. I'm going to ask one more question because due to time, so we can have a Q&A after this. Let me address this question to both Dr. Guerrero and Mrs. Ramon. Let's talk a little bit about shared indicators. If you could name some simple metrics that perhaps that you're measuring now and any progress or lessons learned to share with us today. And these could be day-to-day appointments, postpartum visits within the last 21 days, anything similar to that.
So, yeah, shared metrics. We all have our metrics. We all measure our work all the time. And it's difficult to say, okay, these are the 3 things I think we should all be measuring. I really would like to take kind of like a more 50,000 foot view, is that how are we sharing information about our shared populations? Because of course, like where I'm sitting, one of our priority populations is our jail population. And then anyone who goes through our court system, foster children, aging out of foster children. So any person or family that is interacting with a county government system. And the more we see folks coming through the jail, more than one time, for things like homelessness, for things like substance use, and things, things that people shouldn't be in jail for, right? And I know that you all are all touching those people too. And so what I would love is, how do we share more of that information, whether it's, we have our DVHRT, we have our Family Violence Program Division Director for Preventative Healthcare, and we see, we identify those high risk or the most vulnerable people that are among that particular population, and then get together and share information so that, our hope is that they don't become justice involved. So how can we as the county, or how can we all as public health professionals really look at those populations and do some preventative upstream interventions before they get into our priority populations, which is where nobody wants to be. So I think those are kind of the shared metrics and indicators that I would like to see. And Terry, I'm so sorry. I'm going to ask for a point of privilege like my elected officials do all the time. Excuse me, point of privilege, point of personal privilege.
Sure.
Because the question that we didn't ask, and I know we're out of time and Liz is holding up the 5-minute thing over here, but is, what will it take to scale our work? And like in 6 to 12 months, how can we increase our impact? I guarantee all of you are having impact, but at the same time, in this current environment, we are also having to mitigate harm. And I don't know how many of you have looked at the Texas Sunset Advisory Committee and all of the state agencies that are going to be sunsetted. It's a long list. It's Health and Human Services, it's DSHS, it's dementia, it's regulatory and funding opportunities that are going to go away on top of all of the ones that have already gone away. So what do we need? We need money. Money is the big equalizer, and our funding sources are drying up. And so what I would like to see is, although I love seeing all of your faces because we work so well together, is that we don't engage the business community as much as we should. We need public-private partnerships. We need all of the major employers sitting in these chairs. We need the chambers of commerce sitting in these chairs so that they can see this data, because they're the ones that benefit from a healthy workforce and the ones that suffer from a sick workforce. And I saw Adrian Lopez here earlier. Where is he? Is he here still? You might have left. From Workforce Solutions Alamo, where I used to be a board member and an employee, and, working with Ready to Work and, creating employment opportunities, because it's poverty, it's unemployment, and it's the lack of investment from our private businesses that really have, because I see lots of philanthropy, I see lots of nonprofits, and now we're all competing for the same dollars, and we need a new influx of dollars. And I think that comes from private business.
Excellent
Thank you.
point.
Sorry.
Thank you.
So basically what she's saying is show me the money. I'll be quick.
Money can't buy happiness, but there's very few problems that $100,000 won't fix for most families.
We're going shopping after this. In our SDOH program, we address and measure 4 pathways for our patients: food insecurity, transportation, housing, and financial difficulties. Some of the progress that we've learned is that it takes collaboration on the side of our medical providers and our family service case managers. First and foremost, when we talk about SDOH, a lot of medical providers and medical institutions didn't really understand what that meant, and they were getting one more thing added to their list. So we have to understand that we have different understandings of it and different mindsets, and we go about it differently, but we need to work together in order to accomplish it. So we're looking at this for our very high risk county patients. Family service case managers have access to the electronic health record and are able to document and communicate with nursing staff and patient navigators. This is critical, that we are talking to each other on a daily basis. This allows for less duplication of services and more accountability for the patient. UHS has invested in building in referrals to San Antonio Food Bank, for instance, in their EHR. This ensures that the patient is being referred while in the hospital before they go home. And that's one less referral that our family service case manager has to make. This allows my team to focus on additional food resources to food pantries, programs in the patient's community. We'll talk about housing. Some of the lessons that we're learning on about closed loop referrals. It's very difficult to close the loop on a referral for housing when the wait list is 1 to 3 years. Housing takes so long. We can't keep a case open. We have 100 or 200 more clients right behind them just to measure that, right? So we have to think about different ways of measuring that. Perhaps that's a case manager sitting down and getting that person on the list, filling out that housing application, or it's helping them navigate wonderful tools like Sacred, and teaching them, taking the time. That's right. Woo, woo, right there, Alice. Taking the time to show them that it's on their phone and how to use it, right? I tell my team all the time, we don't give people fish, we teach them how to fish. Take that extra 10 minutes to actually empower that patient and teach them, because the reality is we may not be here tomorrow. All right. Those of us sitting here, we may not be here tomorrow, but at least that patient who's the one that's most in need, they're able to access it on their own. And maybe that's when we'll start seeing some zip code changes, because I lived here 25 years ago. For a short amount of time working for Central Med. The same neighborhoods are needing the same things 25 years later. If we don't work together and we don't start having some real conversations, things aren't going to change. And so talking about these type of things, opportunity home, financial empowerment services from family services, right? Let's get our people equipped so that they can make generational changes. It's not a one, giving someone a box of food, because I'm a food is medicine proponent, right? I'm an advocate. But giving someone a box of food doesn't change their ability to use that nutritional value of a Brussels sprout. I didn't start eating Brussels sprouts till I was an adult. I'm a Mexican. My father doesn't know what a Brussels sprout is, right? But guess what? My Mexican grandmother, she knew what nopales were. And she knew that if she ate nopales before she went to get her A1C checked, she had better readings, right? So the food is, so the power is there. Our people know what to drink. Our people know what to tea. The tea, listen to me. A té de esto, a té de otro, right? Drink a tea, eat nopales, eat corn tortillas. Don't throw rocks at me, Texans. The whole point is we've got the answers, right? We've got to get the accessibility to our people. I'll stop there.
Thank you very much. Great. Now, couldn't you hear the passion come out of each one of these panelists? They gave us a lot to think about. 3 years from now, if this talk here, this discussion didn't come to be realized, shame on all of us. There are some actionable areas that we can work on as a team. But again, we're throwing out data, but let's do something with it. And I think if we can start have meaningful conversations and put them into true action plans, we're going to move ourselves forward. And I hope that this is one of many more discussions to come amongst all of us. And thank you, Dr. Guerrero, for bringing in private enterprise and all the companies in San Antonio that can be very resourceful to us to make our community a better community. So let's give a round of applause to the panelists. And Liz, you want to come back up?
All right, guys, I know we've got a couple minutes left, but we want to make sure we give you room to ask some questions. Dr. McKieran, if you come up or if you want to stay wherever you'd like, I'm sure there's going to be some people that are going to ask questions about the data and the report. We've got 2 people with mics in the back. So if you have jotted your question down throughout the entire event, raise your hand. We're happy to answer it. Okay, we've got Alice right back there.
Okay, not so much a question, but thank you, Dr. Wu, because you brought up collective impact. For those of you who may be familiar with that, and if you're not, go home and Google it and get ready to read, use the Google. Get ready to read for a long time, because collective impact is what will move the needle. It's a coordinated way to take everything we're thinking and wondering, hurting the cats, and finding a way to work together, to take it from transactional to transformational. And I could talk for another hour on this because it's exciting. So thank you, Dr. Wu. We will be in touch. Yes, let's move forward with collective impact. Thank you.
Thank you, Alice. All right, we've got a question right over here.
I appreciate the perspective of bringing the employers into the room to have a discussion. Because one of the challenges that we have, and thanks to Workforce Solutions and other such entities, is that we do have high employment, but we have challenges in medical insurance. And we have even greater challenges when those that are employed can't afford to even go to the doctor when they have insurance, especially when they select such things as high deductible plans when they don't have a net to support those high deductible plans when they have a challenge. So there's, and maybe this is more of a comment than it is a question, but we do have to reconcile the increasing cost of medical with our opportunities as an employer to offer medical insurance that employees, including the Alice folks, can actually afford.
Mm-hmm. And I think thank you for that comment. And I think it even goes a little bit like upstream than that, where we have to start with the living wage. We have to think about childcare and transportation. I mean, as they brought up transportation to and from a job, and then how to reconcile all of those things and still have insurance, and not necessarily just the premiums, but for some folks who have a $40 copay, if you need mental health services or weekly therapy, $40 a week, $120 a month. For a lot of people, that's their water bill or it's their grocery bill. And so all of these things factor into the idea that we need to do. Being employed and having insurance doesn't necessarily mean you're okay.
One really, really quick point about that big bill that was passed this summer is that those high deductible health plans, if it's bronze on the ACA, they are now eligible for HSAs, for what it's worth.
I see the result of people who struggle with having health insurance, but still struggle to see physicians. And by the time someone sees me, and I'm a very subspecialized surgeon, they also have copays to see their cardiologist and nephrologist, their wound care doctor, podiatrist, and me. And still buy green vegetables. There's no doubt that the healthcare system is broken. And I think our solutions are not just going to be here at the local level, at the federal level, which we can talk about. But the other part that we do have impact on is prevention. And so ultimately, you saw the biggest was diabetes, heart disease, chronic medical conditions, and all of those can be prevented by having access to healthy foods and good, safe places to be active and exercise. And so that's what we can do right now, is make sure that we invest in our communities, giving them access to healthy foods, safe places to exercise and be active, and create that environment that promotes that health to prevent these chronic conditions.
Thank you. We've got another question right over here. Okay, and then we've got another one here. So we'll go on this side and then we'll go to you.
So Jason Maciate, I run Hope at Heart Foundation. It's a Children's Cancer Foundation. And so one of the things as I'm looking through this data, which is amazing, so thank you everybody, even for being invited here, is important for us because it's a population that's not focused on at all, pediatric cancer. So in 2025, we're going to have about 300 children diagnosed with pediatric cancer. I am 1 year and 10 months into my role. We have lost 20 children. We have currently 4 on hospice. That's just one organization. So my hope is that we can bring a focus to those families. I cover the non-medical drivers of health so they could focus on the healing of their child. But we just had and I was talking to Dr. Ochoa earlier, we just had a child, 10 years old, got dropped from insurance, stage 4 cancer. So these are the things that are happening here in our community. And I serve about 30 to 40 patients per month. This is here. I partner with all the local children's hospitals. So I'm hoping that our data, and Dr. Guerrero, I will be happy to share this data with you. There's not a lot of organizations that have it, but it is something that is growing, unfortunately. But thank God that we exist in this room, and I'm hoping that we can get more awareness and hopefully collect that data on that. So that's what I want to say.
Happy to meet with you. We met with your team. Because, one of our county commissioners, Rebecca Clay Flores, was diagnosed with colon cancer last year. And so one of her big priorities was to put money in the budget this year for colon cancer prevention awareness. And so we've been talking to your team and to some other folks. So yes.
Beautiful. Thank you. I've got one more question over here.
Yes, my name is Guadalupe Cornejo. I'm a community health worker program coordinator at Northwest Vista College. And my question or comment is along the lines of what Dr. Ochoa mentioned when it comes to prevention and health education. And my comment is my ask for the employers. When we talk about meeting people where they are, that means truly meeting people where they are. A lot of times we meet people on weekends. And so there's a lot of times that our community health worker program is trying to do health promotion programming in the community. And it's becoming more difficult to find partners that are willing to work on weekends, on Sundays, on Saturdays, or evenings. So I really think that the employers should find a way to be more flexible with their workers, find some ways to incentivize people working on weekends. I know all of us that love and appreciate our weekends as our family time. But if we really want to make a difference, consider, meeting people where they are, training your employees to serve with respect and compassion, removing shaming and blaming when you're doing your intake process. I had parishioners that, were trying to get a free mammogram. They had no insurance. Early screening is important. And the way that the questions were asked during the intake process deterred her from like actually moving forward with the mobile unit to actually get the screening, because she felt like she was being shamed just by like, really? You don't have insurance? So again, those things that can deter people when you are at the most vulnerable times of your lives, when you lose your job, you lose your coverage, and asking for help is difficult. And when you actually get there, you are faced with some type of shaming. And so that's just my comment. Thank you.
Thank you so much, Guadalupe. So I know we're a little past time and I want to be respectful of where you need to be next. I'm going to say that our program closes at 11, but certainly this session doesn't close. The opportunity for you to continue to engage, continue to learn, continue to ask the questions. Our panelists and all of you, you're welcome to continue to stay with us. Do we have any other questions before we? Oh, we have one more. Okay. Take one more question.
Hi, I'm from Respite Care of San Antonio, and we are one of the IDD nonprofits in San Antonio. So this question is more directed towards Dr. McKieran about the data. Is there a way, or is there an ability to disaggregate data to focus on or pull data from families with IDD needs or individuals with IDD needs?
It depends on the indicator, which probably you already knew. I think our best bet for that data is our own local data here, people who work with these families and young people to get that data together across agencies and see what we can learn from it, because what we will find from public sources like the Census Bureau or the Burfus survey, that's adults only, but yeah, it's going to be really limited. Even the disability data that we have is limited in terms of level of functioning, which I think is critical to understanding the family's needs.
Thank you.
Perfect. Thank you. All right. We'll take one last question before we close out.
Yes. My name is Adam Rodriguez. I'm with NAMI. I just feel like this is amazing. I'm very impressed by all this data I've been looking over. And it just seems like this is the story of COVID, more or less. It's the time period in which everything changed. I feel like we're living in a paradigm shift. So what exactly, I was looking at the conclusion, what do you see as a panel, or what do you see going forward, like the new trajectory, the outlook from everything that's happened since the pandemic?
Yeah, I think it just came to light, our struggling vulnerable populations. COVID brought it to light. It's been there for decades. I'm new to San Antonio. I've been here for 13 years, but I've learned why I am seeing diabetic amputations on the south side way higher, almost 4 to 5 times higher than that on the north side. And I ask myself why. So the epidemic of chronic illness and disinvestment and lack of access, lack of trust, has been there for a long time. What I hope is that COVID brought to light what's actually happening. I think more people are listening, more private industry are listening. And so the way we're going to have to attack this, I think, is going to be focus on those areas, use this information, use this data, where are the areas of need, and go in and target them collectively together. And I think we have to start at both ends, meaning prevention, as well as addressing something like the fact that we only have 100 acute care beds on the south side of San Antonio. We have over 700,000 population on the south side and only 100 acute care beds right now. University Health is going to build another hospital in August of 2027. That's going to add 166 beds, but that still leaves us of 0.3 beds per thousand population on the south side. Acute care beds are not a solution, but we cannot have communities that don't have access to a place where they have a heart attack, a stroke, pneumonia, a diabetic foot ulcer. As a vascular surgeon, I follow diabetic amputations because they are preventable. And if someone has a diabetic amputation, that means that from birth to by the time I see them, there are multiple areas that have been missed in their social determinants of health, in their access, in their education, in their trust. That also means there's multiple areas for intervention along the way. And so once we move the needle on diabetic amputations, that will mean that everything upstream from there will have made a difference as well.
Thank you. Oh, I'm
I'll,
sorry.
I'll just say that's in addition to the lack or to the need for an additional 300 psychiatric beds. She's talking about acute care. There was a Meadow study a couple of years ago that identified, I think 280, but we're way behind on psychiatric beds as well. And the closure of Texas Vista on the south side made that worse.
Thank you, Adam, for the work that you do at NAMI. NAMI is extremely important to the community. And so thank you, first of all. I think what COVID showed us, and I think that people stay in a COVID mindset. One of the things that have harmed people during COVID, and I worked in skilled nursing in the state of California during COVID, is my patients didn't die from COVID. They died from isolation. Isolation is a killer. And so the more isolated we are and the more fearful we are, right? And so there's a whole generation of kids that were even born into this isolation and this masked framework that we need to get past. And so I'm a part of the Health Equity Network and have been for the last 2 years. And wonderful things are coming from this crazy ingenious thing called a plática. Meeting with people, asking people, opening up a church and having people sit around a table and talking will help us get to the next level. We've got to start talking to each other. We've got to check on our 70-year-olds, 70, I'm almost 70, our 95-year-old neighbor down the street, right? We don't talk to each other anymore. We talk to screens and phones. And the more that we do that, the more isolated we're going to feel and get. And and we weren't even talk about digital equity on the South side or on the West side, but it's about coming out of our shells, being human again, right? COVID just emphasized the fact that we're not talking, and then guess what? The next COVID and the next virus will just continue to do that. If we don't stop, open our doors, open your mouth and talk to someone. And I'm not trying to be facetious or ignorant. I'm just trying to say there's a lot of things that are lacking, but guess what? It doesn't take much to talk to someone and ask them how they're doing, and then do something else that's surprising. Listen.
Yay. Woo, we're taking you on the road. All right, guys, again, thank you. I want to be, again, respectful for your time. So today, we saw how food security, maternal health, mental health, housing stability, they all intersect, and how we can act together. So how is our community showing up? I think all of you guys here today are examples of how we are braiding efforts with each other, with hospitals, clinics, schools, faith partners, community organizations to keep families connected to care. We're aligning contracts, training to stabilize a fragile safety net. And we're also searching for funders and searching with funders for ways to sustain the scale what works. We're deploying practical tools, community health workers, care coordination, referral hubs, this assessment as a shared fact base to close loops between services. And so this is the work that's ahead of us. This is the work that's been a part of us. And so this is, again, just a new platform, new information, as new as we can get it, right, Laura, to you. And the fact that now you have even extended reports into those other rural communities that those families are coming into your service centers, and that the realities of those neighborhoods are sometimes even more dire than the ones we have here in Bexar County. So several organizations and funders are holding the line for families. Metro Health, Methodist Healthcare System, United Way, Bexar County, higher education partners, CNOW, hospitals, everyone here, you're holding the line because that's where we are right now. Thank you for leaning in and helping sustain the network. I can't stress enough to you how important it is for you to continue to contribute to this data source, to continue to contribute to CNOW as our local data authority, if I will, because I think they do a wonderful job. And every single time that you call on them to do a report, you can rest assured that they are not keeping that. They are sharing that. They're expanding that. They're leveraging that every single time. So again, I appreciate you guys being here today. Because of that stewardship, I say again that we stand behind this resource. We ask for you to use it. There are a couple ways for you to plug in now. Explore the data. Scan the QR code. If you want a printed, and we still have some available in the front, please take one. If you need 20, I don't have 20, but maybe we can. I know there was a colleagues of yours that were not able to come today because we had limited space. Let us know how we can bring this report to you. Let us know if there's another opportunity to connect with you and your organizations and your stakeholder groups and bring the data to life for your teams so that you can continue your planning. Join a community health improvement work group. You guys have the card there from Dr. Wu. Please make sure that you're connected to one of those work groups. And even if you don't think that you need to be part of that housing work group or that behavioral health work group or that maternal health work group, reconsider it because everything is connected. And so again, can't stress enough how much we need you at those tables, and we need to think beyond just the service that we're providing in our organizations. And then the last and most important thing again is host a briefing. Please host a briefing. City, county teams, nonprofits, all of you guys, host a briefing about what this report is. We don't like to do a lot of printed copies because we don't want it to just be something we put on the shelf, right? We didn't just check the box. We actually added to the list, right? So think of the report as something that continues to add to the list. Really, really dig into that. We are not afraid for you to ask the questions, to ask the hard questions about why this, why that, why X, why, right? Because we need it, right? We all need it. And so in order for this report to continue to be something that is of use to you so that your user experience is very uniquely yours, and so that this data really becomes your data, because that's what it is. This report is your report. We ask for you to really connect with it and allow us an opportunity to share in that conversation with you. So last but not least, I just want to thank you again for joining. On behalf of the Health Collaborative, thank you for being here. Please stay connected as partners. We appreciate you. If there's more coffee, there's other stuff. These leaders are available. We're available for any questions after this. Enjoy the rest of your day, guys.